Hello and welcome. I'm Dr. Rani Radhakrishnan, and this is my YouTube channel where we discuss about the diagnosis of hematological disorders. I believe that what the mind does not know, the eyes do not see. So we come to another episode of The Scatter Matters, the picture that tells you a story. The picture that is given by the cell counter, which, if we learn how to interpret, will lead us to the diagnosis. It's not just the numbers, but we learn to look at the pictures. In this series, where I have started with an introduction, today we will be discussing the differential diagnosis of macrocytic anemias. As you all know, the causes of macrocytic anemia are many, which could be differentiated as megaloblastic and non-megaloblastic. Megaloblastic, of course, is due to vitamin B12 or folate deficiency, and non-megaloblastic causes of macrocytosis is due to a whole array of uh, conditions which start from liver dysfunction to alcoholism, MDS, hypothyroidism, certain drugs, and hemolysis. Now, will we be able to distinguish the etiology of macrocytic anemia just by looking at the scatter? Well, to a small extent, yes, so that we could go further and do the right kind of tests which will lead us to the diagnosis. Just by looking at an MCV of 100 or 120, we will not be able to come to the diagnosis. Of course, looking at the peripheral smear is going to give you a lot of insight. But will the scatter give us some insight just like the peripheral smear would? Yes. Let's try if we can decode the scatter. So let's go back to the erythrogram, which we have become a little familiar with. So when the volume of the red cell is plotted against the hemoglobin concentration of the red cell, you get a grid, which is the erythrogram, where you have the normocytic normochromic cells which occupy the center of the grid, and the hypochromasia, which will become from hypochromasia, normochromasia to hyperchromasia, and the size of the cell goes on increasing. So by looking at the scatter, one will be able to decide what kind of cells will make up the red cell population in the given sample. Now, this will, to a large extent, correlate with the red cell histogram or the volume histogram and the hemoglobin histogram. So we're going to concentrate on this scatter or the red cell scatter or the erythroid scatter and try and look if we could decode and decipher the etiology of the various macrocytic disorders. Now, this is one patient who is about 40 years old, female, vegetarian, with a hemoglobin which is low, an RBC count which is low, an MCV which is very high, 123 femtoliter, and an MCH which is also high, an RDW which is 26.8, which means that there are all kinds of red cells which are present uh, in the sample. Now, what is the scatter telling us? Let's not look at anything else. Just look at the scatter. This in red is the normal scatter from a normal patient or a normal person. This is a scatter which is from this sample where it's showing you normocytic normochromic cells, but it's also showing you a large population of macrocytic cells which are predominantly normochromic, a small population of macrocytic cells which are hypochromic. It's not showing you any other cells. So there are macrocytes and there are normocytes. And I told you that the histogram will correlate with the scatter. So you have this is the, in red is what is the normal histogram. So you have normocytic cells and you have a large population of cells which are macrocytic. Now, if you look at the red cell differentials, the percentage of macrocytic cells is 53%, which comprises more than half the red cell population. So more than half the red cells are macrocytes, apart from which you have a few 13% of cells being hypochromic cells. Now, the MPXI, which is the myeloperoxidase staining index, because we know that this particular cell counter uses the cytochemistry of myeloperoxidase staining to differentiate or to categorize the myeloid cells. So here, because of the intense myeloperoxidase staining, the MPXI value is also high. There is a positional shift of the neutrophils in the WBC scatter. So, a large macrocytic population, which is predominantly spread in the center portion of the grid, a positional shift of the neutrophils, no real blasts seen, a macrocytosis on the histogram, a raised MPXI. This will give us a probable diagnosis of macrocytic anemia due to vitamin B12 deficiency or megaloblastic anemia. So these are pointers which, if we apply when we are looking at the scatter, we will be able to come to a diagnosis. So this is a classic picture of megaloblastic anemia. Let's go on to the next scatter, which is a 36-year-old male with a deranged liver function tests. So here what is happening is the scatter is extremely narrow and it's just got normocytic cells. That's all, normocytic cells. A hemoglobin is normal. If you see, there is no broad-based scatter at all, which was there when we saw the megaloblastic anemia. Here the scatter is narrow and it just occupies a small portion of the grid. So here if you see, the hemoglobin is quite normal, the MCV is high, and you will see a normocytic population and a macrocytic population. So this is a case of alcoholic liver disease or a red cell population where you have deranged liver function tests or a macrocytosis secondary to liver cell dysfunction. So you can differentiate a vitamin B12 deficiency from an alcoholic liver disease. Now let's go on to the other causes. So here we have a 26-year-old male with fever and anemia. So what has happened here is, again, you have macrocytosis with an MCV of 115. So if you look at the scatter, you have a macrocytic cell population and you have a normocytic cell population. So these are two distinct cell populations that we are seeing on the scatter. It's not a single population like we saw in the other scatters till now. Even if you see over here, you'll have a whole population of red cells which are normocytic normochromic, and you have another population which is macrocytic. So there are two distinct cell populations as evidenced both in the histogram and in the erythrogram. So which means that if we try to extrapolate, if we try to think harder, what does this macrocytic cell population do to? So the most common cause of having a cell population that is so distinct or two distinct cell populations is the presence of red cell agglutination in the sample. Most commonly because of cold agglutinins or mycoplasma pneumonia or due to drug-induced disorders, any other reason which could cause agglutination of red cells in the tube. So when we feed these tubes into the cell counter, apart from the MCV and MCH not correlating and the hematocrit not correlating, where the numerical values don't make sense at all and you don't know how to release this, the looking at the scatter plot, looking at the histogram tells you that there are two distinct populations, one of which is macrocytic, and that macrocytosis is not true macrocytosis, but it's because of red cell agglutination. So this is a very classical scatter plot that you get with red cell agglutination. Now, the next case does not give you an MCV which is higher than 100, which would say that it is macrocytic anemia. However, a look at the scatter tells you that there is a large proportion of macrocytic cells, which is about 28%, which is roughly more than 1/4 of the population of red cells in the sample. So just looking at an MCV of 96 will not tell you that there are macrocytes in the sample. You need to look at the scatter or the histogram, which will tell you that there are different kinds of cells in this sample, or different sizes of red cells, or different chromasia of red cells. So one needs to look at the picture, and looking at the numerals here, looking at the numerical values alone is not going to tell you what kind of cells we are going to be having in this particular sample or for this patient. So if you look at the scatter here, it's kind of in all the 9 quadrants of the grid, you have a population which is normocytic, normochromic, you have macrocytic population, you have microcytic population, you have a hypochromic population, and you also have a hyperchromic population. So if you look at the histogram, I have microcytosis, this is the volume histogram. I have microcytic cells, normocytic cells, macrocytic cells. If I look at the histogram, I have hypochromic cells, I have normochromic cells, and I have hyperchromic cells. So these two correlate so beautifully, and we don't really need to look at the numbers at all. We can just look at these pictures, which are telling us so much of information. Now, if you look at the differential, it's 28% of macrocytes and 22% of hyperchromic cells. It also gives you the total number of RBC fragments. It is 0.08. Anything more than 0.05 becomes significant over here. So you have a huge population of red cells which comprises a mix of macrocytes, microcytes, and normocytes, hypochromic cells, hyperchromic cells, and also red cell fragments. So just by looking at the histogram and by looking at the scatter plot and later correlating that with the numerical values, one can come to a diagnosis of red cell fragmentation or hemolytic anemia. You also have nucleated red cells over here, which because of which there is a corrected count and an uncorrected total WBC count. So there is so much of information. You can get the nucleated red cells by looking at this scatter plot. You can get the presence of hyperchromic cells or spherocytes from this scatter plot, macrocytes, which could signify reticulocytes. And if you do a retic stain on this, if you do a reticulocyte count on the cell counter, you can also look at the retic scatter, which will tell you more information. So this scatter, where we don't strictly have macrocytic anemia, but we do have presence of macrocytosis, probably because of the presence of reticulocytosis. This is a diagnosis of hemolytic anemia, which we can pick up so wonderfully by looking at both the red cell scatter and the red cell histogram and some information from the WBC scatter plot also. So this will tell you that this is a case of hemolytic anemia, probably because of red cell fragmentation or microangiopathic hemolytic anemia. Now moving on to another case. Here again you have a low hemoglobin, 7 grams, and an RBC which is low, and a macrocytosis where the MCV is 123. Now, if you look at this scatter also is kind of all over the place. You have normocytic normochromic cells, macrocytic normochromic cells, macrocytic hypochromic cells, very few hyperchromic cells. So again, it is a broad-based or widespread scatter plot where you again see the histogram having normocytes and macrocytes and predominantly normochromic cells with very little of hypochromasia. You have blasts in the basoscatter, you have blasts in the peroxscatter, and you have a high MPXI, which means that there is some increased myeloid activity that is happening in this sample. Now, this is a case of a 56-year-old male with a history of recurrent transfusions. Yes, you must think or you must keep megaloblastic anemia at the back of your mind, but usually in megaloblastic anemia, the scatter does not go to the left. The scatter is mostly confined to the center of the grid and a little bit to the right. It does not really go to the left of the grid. This is usually the case of uh, myelodysplastic syndrome. In cases of myelodysplastic syndrome, you will have various shapes of the scatter, and the scatter usually tends to occupy a major portion of the grid. It could occupy, say, almost all the 9 squares, or it could occupy the center portion and the upper portion of the erythrogram. So this is how you differentiate it from megaloblastic anemia. So the shapes of the scatter are more or less significant. They're more or less characteristic. And by repeatedly looking at them and obviously comparing it initially with the gold standard, which is the peripheral blood film, you will be able to make this connection in your head as to which scatter signifies which pathology. And once that neural network is done in our brains, then just the mere sight of the scatter will be enough to tell you, to forewarn you, or to give you an idea of what kind of pathology we are dealing with. Here again, if you see, more than half the population of the cells are macrocytes, but you don't have the rest of the other cells. You have a blast suspect of 7%, which is seen here on the basoscatter and seen here on the peroxscatter. So I think more or less we are uh, clear that this is not megaloblastic anemia, but it's most probably a case of myelodysplastic syndrome. So we've looked at the scatters and we've learned to differentiate to a reasonable extent the various causes that could lead to macrocytosis. So if I would summate, the red cell scatter plots help us to classify the macrocytic anemias based on the etiology to a reasonable extent. Definitely, we are much better informed by looking at the scatter as to what could be the cause of the macrocytosis in that particular patient. And if you correlate it with the white cell scatter plots and the other data that is available from the cell counter, you can more or less come to a reasonably good diagnosis, which would correlate very well with the findings on your peripheral blood film. Thinking visual makes hematology fun. Learn to think visual so that we can enjoy this journey and start appreciating the scatters and the pictures much more. Thank you for watching. Please subscribe to my channel for more such videos. Thank you very much.